This is Dr. Jennifer Robinson, a plastic and reconstructive surgeon with the Victoria Breast Group. Regardless of where you are in your journey with breast cancer or where you live, breast reconstruction is an option available to you. This video is intended as an introduction to the various breast reconstruction techniques. If you have had one or both breasts removed due to breast cancer or prevention of breast cancer, you have the option to have your breasts reconstructed. This choice is very personal, but in our experience, it completes your journey with breast cancer. Breast reconstruction is covered by provincial health insurance and can be performed at the time of a mastectomy or at any time afterward. If reconstruction is done at the time of the mastectomy, two types of mastectomy can be performed. First, a skin-sparing mastectomy, in which the nipple and areola complex are removed, or second, a nipple-sparing mastectomy, in which an incision is made on the breast but no skin is removed. Your cancer surgeon and your plastic surgeon will discuss which approach is best for you. Reconstruction options fall under three major categories. The first, and perhaps the most common reconstruction performed worldwide, is implant-based reconstruction, which uses prosthetic breast implants. A temporary silicone tissue expander is placed underneath the pectoralis muscle and inflated with saline as much as is safely possible in the operating room. It is further inflated in the office on a weekly or bi-weekly basis until the desired volume is achieved. The length of time it takes to complete the expansion phase depends on how much fluid was inserted at the time of surgery, how much fluid can be inserted during office visits, and what the ultimate volume goals are. A second short operation is then performed to exchange the temporary expander for a permanent implant, either saline or silicone. This can be discussed with your surgeon. Sometimes women are candidates for a direct-to-implant reconstruction, where, at the time of the mastectomy, a permanent implant can be placed underneath the pectoralis muscle. A material called acellular dermal matrix is used as a sling to help position the implant underneath the muscle, at the desired place on the chest wall. This allows for a one-stage immediate reconstruction. The dermal matrix is derived from donated human skin that has had all of the cellular elements removed from it. It is non-allergenic and serves as a scaffold into which your tissue grows, rendering it part of you. If you have had or will have radiation therapy, implant-based reconstruction is avoided. Each surgical stage is day surgery. The advantages of implant-based reconstruction are: it involves short operations and recoveries, allowing a quick return to your life's normal activities. It doesn't require any surgery, pain, or scars elsewhere on the body. It allows for some control over ultimate breast size. The disadvantages of implant-based reconstruction are: it requires the use of a foreign, man-made device that resides in your body and is subject to the risks of infection, implant malposition, and scarring around the implant called capsular contracture. It requires multiple visits to the office if undergoing the two-stage process. It is difficult to achieve symmetry with the other breast. The second major category of breast reconstruction is autologous tissue reconstruction, which involves using your own tissue. Flaps of tissue with their own blood vessels are taken most commonly from the abdomen in a tummy tuck fashion. This is called a deep inferior epigastric perforator, or DIEP flap. The tissue is transplanted to the chest wall, where the blood vessels are connected using microsurgical techniques. If the reconstruction is done at the time of a skin-sparing mastectomy, usually a small circular paddle of skin is visible from the transplanted tissue and is used to recreate the nipple areolar complex. When done long after the mastectomy was performed, the skin paddle is much larger, and the skin that was removed during the mastectomy must be replaced. The donor site is sutured. If not enough tissue is available on the abdomen, other flap donor sites can be used. Patients stay in the hospital for approximately 3 days post-operatively. The advantages of autologous tissue reconstruction are: it is the most natural-looking and feeling reconstruction. It avoids the use of a foreign body implant. It is a lifelong reconstruction that requires little or no maintenance. A tummy tuck is a benefit of the procedure. Symmetry with the other breast is easily obtainable. The disadvantages of autologous tissue reconstruction are: it takes 5 to 6 hours for one side and 7 to 8 hours for both sides. There is a 1 to 2% risk of failure due to a blockage of blood flow in the flap. This is one of the reasons for monitoring you while in hospital. Recovery is approximately 8 weeks, and a tummy tuck-like scar results at the flap donor site. The third category is a latissimus dorsi flap reconstruction, which is a hybrid using both an implant and your own tissue. This type of reconstruction involves taking a paddle of skin attached to muscle from the back and leaving this tissue attached to its blood supply. It is rotated around to the front of the body and used to drape over an implant to protect it from the effects of radiation therapy. Sometimes a tissue expander is used before an implant is placed in order to allow more control over the size of the final reconstruction. In rare cases, the flap alone can be used without an implant if the intended reconstruction is small enough not to require the added volume. Patients stay in the hospital overnight. The advantages to the latissimus flap are: it allows a reconstruction that looks and feels more natural than standard implant-based reconstruction. It decreases the rate of complications like infection, implant exposure, and painful capsular contracture that occur in radiated patients with implant-only reconstructions. The disadvantages to the latissimus flap are: it leaves a scar on the back that fits into the bra line. Implant-related complications can still occur, although less frequently than with implant-based reconstruction alone. If an expander is used, it requires multiple visits to the office. During the first stage of any type of reconstruction, drains are placed and sutured to the skin in order to avoid fluid accumulation after the surgery, called a seroma. The nurses in the hospital will teach you to care for them and record the outputs. They stay in place for a couple of weeks and are removed in an office follow-up visit. Seroma formation rarely occurs after the drains are removed and may require repeat drainage in the office. Reconstructions usually involve one or more revisionary procedures that are short and outpatient-based, requiring little recovery time. Each procedure brings you closer to your ideal reconstruction. Often, fat grafting is used to fill volume or contour deficiencies. The final stage involves recreation of the nipple areolar complex. Small flaps of your own tissue are rearranged to create a nipple mound, and afterward, tattooing is used to place the areolar pigment. Although scars fade over time, this final stage completes the reconstruction and detracts away from the visibility of them. Reconstruction is an entirely personal decision, but our patients report great satisfaction in completing their journey with breast cancer. We look forward to discussing the options further with you.